Good morning, everybody. Thank you so much for coming. The one good thing about speaking at 6 o'clock, if I make a mistake, people may be too sleepy to even recognize it. So, some of my disclosures. So the learning objectives will discuss the current state of intestinal failure, review some of the predictors of enteral outcome and intestinal failure, and discuss some of the literature known about puberty and growth in children and adolescents with intestinal failure. We've come a really long way since this was described in the late 60s, the use of TPN for an infant who had an ileoatresia and was sustained using these machines. And as you see, we've come such a long way with kids having these pumps that no one can see and these backpacks. So when we think about how we've come for intestinal failure, we can think about the early 1950s, when the first transplant was done. We see over time, we know now what causes cholestasis in our patients. We've had advancements in transplant with immunosuppressive medicines. Patients are living longer and longer. We're using alternative lipids for these patients, and now we're using GLP-2 analogs to help enhance adaptation. So we have definitely come a long way since we first started in this area in the 50s, and as Dr. Jane talked about yesterday. So when we talk about intestinal adaptation, this is this compensatory process that occurs following extensive intestinal resection, wherein structural and functional changes in the intestine improve nutrient and fluid absorption. Dr. Kelly Tappenden has done a lot of this work and has written some really nice reviews. And this just simply goes over and talks about the normal intestine that we have and the impact of adaptation. What affects adaptation? So patient-related factors such as the initial insult that the patient may have had, the status of the residual intestine, what's left, the microbiome, growth factors, and other nutritional factors. And the goal with this adaptive process to see improvement in villus and crypt length, improved function of the intestine, decreased transit time, and blood flow. When we think about intestinal failure, some groups have really broken it down into type 1, type 2, and type 3. So those type 1 patients are those who may have jejunostomies or stomas. Type 2, those who are attached from jejunum to their colon, and those who have type 3 disease, where they're put back into continuity. And this is a group of patients that probably have more issues because they're unable to recruit their colon in order to be able to improve fluid and water absorption. So as a result, we have to use use PN to produce these extra calories and nutrition. So intestinal rehabilitation, when we think about this process, this is a review that Brad Warner and his group published a few years ago. We think about the nutritional support aspect of it. What enteral feedings are we providing? Are we able to provide breast milk for the patient? Are we trying to avoid oral aversion, which is probably one of the biggest concerns some families have because their kids won't eat because of the prolonged illness that they had when they were younger. Which lipids are we using? We're using alternative lipids. How are we preventing vitamin and mineral deficiency? How are we screening for it? Then we try to avoid the complications. So the bacterial overgrowth, potentially leading to resistant organisms, depending on how you're using your antibiotics, trying to reduce or change the dietary that the patient's actually receiving, preventing renal dysfunction. These patients get a lot of nephrotoxic drugs during their course. How do we monitor that? Looking at dehydration. And of course, IFELD, which, really early in the early 2000s, these patients were dying from liver disease. And they died waiting on the bowel transplant list, or they were never able to be transplanted. And clearly sepsis, which these patients are at risk for. And enteral autonomy is that ultimate goal. How do we promote adaptation? And the early provision of luminal nutrients is important. Teduglutide is one other aspect. And the surgical strategies. There are different tapering procedures that the surgeons are able to do. And in some cases, the patient still may need to go on to transplantation. When we look at the more recent data, looking at the trends in outcome, this was an international registry, including the US, Canada, Europe, and it looked at 443 patients who had intestinal failure and looked in at their ultimate outcome, with, of course, about 50% or so were able to achieve enteral autonomy, and definitely you saw a reduction in the amount of patients who underwent transplantation at that 72 months, about 17% compared to 11% who unfortunately died. When you go back and look at that initial PIVCon paper, that Intestinal Failure Consortium paper, if you compare it, it's similar in the sense that the amount of enteral autonomy was 47%, so a little less, but you definitely saw less patients that died and less patients that went over who unfortunately died. So patients who now we know we're able to treat them better, and they're having better transplant-free survival. So how do you predict enteral outcome? This is from the Intestinal Failure Registry. The first author is here. So looking at what predicts better outcome. And so this is a group of patients, 189 patients, pretty common. 82% of these patients had intestinal failure. Some had mucosal disorders. And looking at what their condition was at baseline, about half of them had stomas, a third of them had liver disease, some of them had antibiotics for bacterial overgrowth, some of them were using anti-diarrheal agents, and they had about 32% of their remaining bowel remaining for the median. So this was also a group of patients throughout the country and the world that are in this registry. And what they found was they actually had patients that did quite well, as far as about 50% patients achieving enteral autonomy, and a smaller percentage, about 7% of the patients actually dying. When you looked at what portend or worsened outcome, it's actually the presence of an ostomy. And so I think this is part of the surgical strategy now, is to try to reconnect patients. And this also supports that theory that reconnecting them and perhaps putting their colon in continuity can help with absorption and help with them achieving enteral autonomy. So when we think about our patients, we don't always think about what the burden is at home, how much they're actually doing. And I think when we're discharging families, it's very difficult for these families. You're essentially discharging them to be a nurse at home. And some of these families are fortunate enough to have home care nurses, but depending on where you live in the US, you may or may not have significant home care nursing that can be at the home for 6 to 8 hours, or even more than that during the week. And so this is the group at Toronto that looked at carrying the burden of caring for these patients, a pretty typical patient population with the mean age about 3 plus or minus 7.9 years. And the majority of these patients, the mother was the actual caregiver. And these are the demographics of the patients, pretty typical that most of us will see in a patient population in a large intestinal rehab program. And they actually broke down the division of time these families spent on a variety of different tasks. 26% of the time is spent on PN, 20% on enteral nutrition. So that's almost half of what their time is. And if you look at the actual amount of hours that they were spending, the median was about 30 hours, with ranges up to 45.7. I mean, that's a full-time job that they're doing to take care of their patients. And so this is something that's important and that we always should keep in mind when we're caring for these patients, the burden that they're actually having. When you think about quality of life, this was a more recent paper that was published looking at a cohort of patients who had intestinal failure. It was a cross-sectional study, 29 that were PN dependent, 27 that were weaned from TPN. And of course, what you found was those patients who had or continuing to receive TPN, the family well-being was less. And there was a lower quality of life in families who the child was on parenteral nutrition. And those kids also had higher or had more gastrointestinal symptoms. There was really no difference between the PN dependent and those weaned from TPN with overall health quality of life. We have patients now that are living longer and longer. And this was the group in France that looked at their experience. They had 36 patients, median follow-up of 17 years. And what they found were that the patients who had persistent intestinal failure, 88% of the patients who underwent transplant had gastroschisis, and those patients with ostomies had persistent intestinal failure. So as we're seeing these patients longer and longer, we're going to start seeing different diseases that they may have. This is a Boston group, and they published several years ago looking at their long-term outcome in children cared for between 10 and 19 years of age, looking at how many patients were ultimately tapered from their TPN. And so at 10 years, they had a probability of about 70% of these patients being tapered successfully from TPN. So when we think about intestinal adaptation, that is the ultimate goal when we're caring for these patients. They have longer and longer transplant-free survival and development of enteral autonomy. Intestinal length, presence of a stoma can affect outcome. And as these patients are surviving, we need to know more about what outcomes they can have. So we're all also pediatricians, so growth and puberty was something we learned during our training. And so this is from Nelson's Pediatrics, just kind of going through early adolescence, middle adolescence, and late adolescence, and talking about the different physical characteristics that male or female patients may be having as they go through these different stages of adolescent and the different sexual maturity ratings. So the period of development of puberty is marked by growth acceleration. I mean, that's when you're gaining in height. You may see alterations in body composition and also secondary growth sex characteristics. And the onset of puberty is going to vary by age, by sexes, and even so with different ethnic groups. When we look at the signaling for puberty to start, it's a very complex process. Pulsatile gonadotropin releasing hormone is really at the center of this that is triggering puberty. But there are other aspects to puberty also, including leptin. Leptin is actually produced by adipose tissue, and it's also another signal to the reproductive system that the body can undergo puberty. So as you can see, it's a very complex process, and we have different patients in pediatrics that may be stunted or may have a delay in this process because of their underlying condition that they may actually have. So when we think about, this also is from Nelson Pediatrics, schematic representing, this is from a different article, postnatal growth velocity. So you have awakening of the adrenal gland. And so the adrenal gland is causing development of body odor, oily skin, hair, development of pubic hair. So this is usually occurring around ages 6 to 8, and it's independent of true central puberty. So you have a production of different androgens by the adrenal cortex, including DHEA, S, and other hormones. So growth and linear growth acceleration really begins in early adolescence for all genders. And so 15 to 20% of adult height is actually achieved in puberty. And so if you potentially have a delay in puberty or are stunted, this can affect what your ultimate growth will be. We definitely see this in our patients who have inflammatory bowel disease. And there's always been concern for and there have been reports of patients with intestinal failure having stunting or delayed growth also. So what heavily influences the timing of puberty? So genetic and environmental factors. So genetic determination, how tall are your parents? That's going to determine it. When did they start undergoing puberty? That's going to also affect it, with 50 to 80% of the variation in timing being genetically determined. So individuals progressing into puberty late will frequently have a parent who also had a similar pattern at that point. And when you look at all of the different impacts on puberty, nutritional status is also very important. And so these patients that we're monitoring, we're seeing them in clinic, we're looking at their growth, we're looking at their weight, and depending on how much malabsorption that the patient's actually having, how much TPN support are you providing them. But also in pediatrics, the patients who have inflammatory bowel disease, other conditions may play a role. Environmental factors may have an impact also, and different prenatal potential conditions. So this was a nice schematic, just kind of going through how different non-nutritional factors can affect pediatric IBD. In some ways, there is some overlap or similarity with our intestinal failure patients, especially those who've undergone resections. They may have malabsorption. Some of those IBD patients also have high stoma output, which we may frequently see in our intestinal failure patients. So this increased GI nutrient losses is contributing to malnutrition and potentially puberty delay. The IBD patients, of course, are somewhat different in the sense that they may also have different drugs that are affecting their growth, whether it's corticosteroids that may be affecting it or how long they've actually been affecting it. When we think about what we're actually providing our patients in the intestinal failure clinics. ASPEN, of course, has a lot of recommendations that we can use in order to look as what exactly are we putting in our TPN? What exactly are we measuring for our patients? How frequently are we measuring some of these different products? And looking at the different vitamin minerals that perhaps we need to be providing extra from our patients simply because the malabsorption that they're having and the needs we need to present for in their parenteral nutrition. Where's the data talking about puberty and growth in intestinal failure? Well, this paper was actually published a few years ago from the group at Boston, looking at puberty and growth in patients with intestinal failure. And there have definitely been reports of patients who've had poor growth, especially as they hit puberty and actually needing to be placed back on TPN. So they looked at their large cohort of patients to see the evidence for this within their group. They looked at outcomes of interest, such as peak height velocity, the age of their peak height velocity, and the age of puberty, Tanner stage 2 in these patients. So again, this was a typical patient population. I think it was about 110 patients that they followed. As you can see, the median birth weight was about 2.2 kilos. They were 34 weeks gestational age. They had a variety of different other comorbidities, but a pretty typical IRP patient population with about 30% of the patients having NEC, which NEC is the most common cause of short bowel syndrome. They had patients who had gastroschisis, volvulus, and intestinal atresia were the other two leading causes that they saw. They looked at the nutritional status of these patients at the last follow-up. Some of these patients were completely enteral fed. Some of them were primarily parenteral fed, and then there were patients that had a mix. They looked at the variety of different hormones or other therapies some of these patients were actually had, and they found their bone age Z-score was about minus 0.25, and they looked at their other anthropometrics. When they looked at females, they looked at females and they also looked at age. And as you can see, they compared them to the standard CDC growth. And what they also found was that looking at the percentage of patients with puberty outset was about 11.2 for the female population and 13.4 for the male patient population. When they looked at comparison versus norms, so they stratified this by sex, and what they found was that females actually had had earlier on puberty. So they had a mean age of peak height velocity that was less than the norm, so they started at an earlier age. And they also saw that for males, they were younger with their onset mean age of peak height velocity, and also a little bit older for their mean peak height velocity. So their conclusion was that puberty onset and growth was not significantly delayed or diminished in patients with intestinal failure, but what they did find was these patients tended to be short. And so why was that? I think that other people have also seen that these patients tend to have shorter stature. This was a paper that was actually published in 2023 by the group in Cincinnati, looking at age-related trajectory of bone density in children with intestinal failure. And so this was a longitudinal retrospective cohort study. This was 34 patients cared for between the time period of 2012 and 2021. They had been diagnosed by intestinal failure at least by the age of 10, and they had at least 2 or more DEXA scans. And so they excluded patients who had other metabolic disease that may have an impact. Again, pretty typical patient population, looking at the gestational age, their mean was about 35. 76% of the patients were preterm infants. A lot of the patients had resections. Majority of the patients were in continuity. They did have a third of them who had their ileocecal valve present, and a little less than half of them had some sort of colonic resection. Again, typical patient population, although they probably had a few more gastroschisis here, neck patients, typically what we would see in our patient population. What they found was the mean height Z-score was minus 1.5, plus or minus 1.3. Their mean bone density Z-scores was minus 1.5, plus or minus 1.3 also. 25 out of 34 of the patients had Z-scores less than minus 2 for their bone mineral density. But these patients also were shorter. So you had to adjust the height, age, Z-scores to be able to interpret their bone mineral density scores and their standard equations to be able to do this. And so they found about 11% of those patients when they did those, when they made those adjustments, had scoring less than 11% less than minus 2. So bone density scores were slightly increased with age, and they had a lower parenteral nutrition dependency and were higher in scans without an artifact. So some of these patients have G-tubes. A lot of these patients have G-tubes, and that can cause some artifact when you're doing the DEXA scans. So what was interesting, the etiology of intestinal failure, line infections, prematurity, and vitamin D status were not associated with height-adjusted bone density Z-scores. So in conclusion, puberty is a complex process that's dependent on multiple factors, including genetic, environmental, and nutritional. One thing I neglected to mention earlier, one of the questions was, why would these intestinal failure patients have puberty early? And so there's some papers that are showing that patients that are premature may have earlier onset, and a number of those patients in that prior study actually had also prematurity. We also know just overall in the US and Europe, different places, kids are starting puberty earlier. So how much is that playing a role also? We definitely need more data, more prospective study when we're looking at puberty delay in these patients. And there's definitely evidence. I showed you some papers, and there are other papers showing that these patients may be short. And monitoring growth is so important in this patient population, including the nutritional components of the enteral nutrition and the PN regimen.